Hello. Can you hear me? No, I think you are. Hello.
Prani.
Yes.
Okay, there how many systems are on?
It is.
Some systems mic is on. No?
Yes.
There, tell everyone to mute the mics. Tell everyone to mute the mics. No, still. Okay, now you speak.
Hello.
Continue, speak something.
Hello. Same.
Yeah, now you speak. Now you speak.
Hello. Good afternoon.
Hello. Is it okay?
Hello. Yeah, 1 minute. I also will say. Hello.
Hello.
Prani, yes.
What? Hello.
Yeah. No.
Hello. Hello.
So that is required. That would happen.
What is it?
Hello.
Hello, good afternoon. Knowledge. Hello, good afternoon.
Hello.
Okay, laptops. Good afternoon. Hello. Should I start?
Hello. Hello. Is it audible?
No,
It's audible,
I
then,
can't
no?
see.
You can hear me?
Yes.
Okay. It's audible.
Hello.
No, you won't be able to hear me. You can hear me. Okay. Now you speak.
Hello. Only mine is off.
Your speaker is not
Yes.
മ്യൂട്ടല്ലേ ഇരുന്നത് മ്യൂട്ടല്ലേ ഇരുന്നത് No? Me? Speak, no? Speak.
Hello.
Ah. Once more. Yeah, no.
Hello.
Okay.
My voice can be heard.
You can unmute and speak.
1 minute. I'll talk again. You can hear. Hello. Knowledge is power. Information is liberating, and education is the primus of progress. An investment made in knowledge pays the best interest. A very good afternoon to all the delegates and the resource person of today's webinar, Dynacon 2023, hosted by Department of Homeopathic Pharmacy to mark the 25th year of PG courses in homeopathy at Father Muller Homeopathic Medical College. Homeopathic pathogenetic trial, also known as homeopathic drug proving, is one of the fundamental concepts of homeopathy and has been conducted for more than 200 years. In addition to exposing the toxic effects of the drug, homeopathic drug proving serve as a key source of information for homeopathic materia medica. Now, I request Dr. Blaney Lobo, Head of Department of Homeopathic Pharmacy, to deliver the welcome address.
Small cheer and great welcome make a very feast. Good afternoon to one and all. On behalf of the college and on behalf of the pharmacy department of our college, Father Muller's Homeopathic Medical College, I extend a gracious and warm greeting to all our delegates who have joined us here today. It is heartening and gratifying to see so many familiar faces, peers, students, teachers, seniors, practitioners, old batchmates, and my colleagues. We have gathered here with a common objective of learning and understanding the intricacies and complexities of drug proving. Homeopathy without drug proving is much like science without Einstein or India without the Mahatma. It is an honor and pleasure to head a brilliant and accomplished team of staff members of pharmacy department who have left no stone unturned to make this webinar a great learning session. Kudos to Dr. Ram Jyothis, a true follower of Master Hahnemann and an authority on his own, for gracing this function as a speaker. I thank the administrator, principal, vice principal, and management of our college for providing all the support and help we require to organize the webinar. I once again raise my hand and salute to all of you who have made time to join us today for this meet, despite your obligations and commitments, and fervently wish that all of you have a happy and rewarding learning experience today. Thank you once and all.
Thank you, sir. Now I invite Dr. Vilma D'Souza, Vice Principal, to convey her message for the day.
Good afternoon. Good afternoon. And welcome to Dynacon 2023 online webinar. Good afternoon and welcome to Dynacon 2023 online webinar. I'm happy to address you today as the Vice Principal of Father Muller Homeopathic Medical College. I'm seeing so many eager minds gathered here from different colleges for this online webinar. As we celebrate 25 years of postgraduate Silver Jubilee celebration this year, the postgraduate departments organizes different events in this year. And today, last month, we had the Department of Preparatory has organized the seminar. And today, the Department of Pharmacy of our college organized webinar on Dynacon 2023 on the topic Homeopathic Pathogenetic Trial, Protocol and Symptom Analysis. I encourage all the students to actively participate, ask questions, and engage in discussion throughout the sessions. Remember, your role as student and future professionals in healthcare is important. The knowledge you gain here today will not only shape your careers, but also contribute to the safety and well-being of individuals. I extend my sincere gratitude to our administrator, Reverend Father Roshan Krasta, and also the Assistant Administrator, Reverend Father Ashwin Krasta, Principal, HOD Dr. Blaney Lobo, and all the departments of pharmacy to support the students to participate in this webinar. I extend my sincere gratitude to our distinguished speaker, Professor Dr. Ram Jyothis, Site Investigator, CCRH Drug Proving Research, Kottayam, for his time and expertise. Thank you once again for being here. Let's make the host of this opportunity to learn and grow together. Thank you and wish you all the best.
Thank you, ma'am. I request Dr. Vivek Shaktidharan, Professor, Department of Homeopathic Pharmacy, to introduce today's speaker.
Good afternoon, everyone. It's my honor to introduce our resource person for today. Our resource person, Dr. A.B. Ram Jyothis, he has completed his BHMS and for MD, he has specialized in the subject of homeopathic pharmacy. He started his teaching career as lecturer in the Department of Pharmacy at Father Muller Homeopathic Medical College in the year 2006. He is currently working as professor and in the Department of Homeopathic Pharmacy at ANSS Homeopathic Medical College, Kottayam. He also has a fellowship in scientific writing and research methodology. He is the site co-investigator for drug proving project of CCRH. He is a certified journal reviewer from Publon Academy, and he is also a resource person for pharmacovigilance program of the Department of Ayush Government of India. And he also has been a resource person for the ROTP in homeopathic pharmacy. So with all the credentials, he is a right person to speak on this particular topic. So without much ado, I welcome our resource person for today, Dr. A.B. Ram Jyothis. Sir, over to you.
Thank you, Dr. Vivek. I am very delighted to see all my former faculty in Father Muller's. And I'm very happy to be a part of Dynacon on the occasion of 25th year of PG courses in homeopathy in Father Muller Homeopathic Medical College. And I am always cherish the memories of being the faculty of Father Muller's and be a part of PG programs in its initial years when Father Muller's started PG courses in the 4 new subjects in 2006. The topic which I am going to discuss today is homeopathic pathogenetic trial, the protocol, and the symptom analysis. So before that, let me ask, my voice is audible?
Yes, you're audible.
Audible. Okay. So I am sharing my screen. Screen is visible? Okay, oh, great. So the topic is homeopathic pathogenetic trial, the protocol, and symptom analysis. So all of you know that homeopathic pathogenetic trial is it's not a new term. We all know. So this term, homeopathic pathogenetic trial, was introduced few years before for drug proving. So we all know that drug proving is a method which is unique to homeopathy, where the pathogenesis of a drug is evolved through its trials on healthy human volunteers or provers. And all of you know that proving is an important part of homeopathic theory and a mainstay of his practice since the first proving of Cinchona officinalis by Dr. Hahnemann. And also, we know that Dr. Hahnemann is also known as father of experimental pharmacology, because he developed a new principle for ascertaining the curative power of medicinal substances, which laid the foundation of drug proving and detailed the process. So we also know that he tested or he proved 99 drugs by himself, his family, on his colleagues, in order to discover the effect of the drug on healthy individual. Now, the proving, the main objective of this proving is to identify the therapeutic potential and primarily study the action of this drug on healthy human beings. All of you know. The symptoms produced by healthy provers form the basis of developing a homeopathic media which identifies the symptom indications on which the drug can be prescribed to the patients. So nowadays, most of the colleges, they are conducting drug proving programs. So with the help of or without the help of CCRH protocol. And we all know, I already told that Hahnemann was also, he was called as father of experimental pharmacology. And you all know, in Organ of Medicine, aphorism 105 to 145, Dr. Hahnemann has detailed the instruction regarding the method of drug proving in healthy subjects. You all studied about it. And after Hahnemann, many provings have been conducted by number of authorities. It can be associations, it can be societies, it can be individual persons, most of whom have devised their own methodologies. And many may have advantages, some may have disadvantages. We know, apart from the standard Hahnemannian protocol or Hahnemannian methodology, we have homeopathic pharmacopoeia of metastates protocol. We have Liga Medicorum Homeopathic International Protocol, LMHI protocol. We have a European Committee of Drug Proving or European Committee for Homeopathic Drug Proving Protocol. We have CCR, Central Research in Homeopathy, Central Council of Research in Homeopathic Protocol. And we have certain protocols by individuals like Rajan Shankaran's protocol, Jeremy Scher's dynamics protocol, etc. So all these protocols aims to identify the therapeutic potential of the drug by the action of these drugs on healthy humans. Now, what is a study? So before going into the protocol, let me clarify one thing. I am associating with drug proving project of CCRH for the last 10 years. And before that, we have conducted many drug proving projects in college as a proving supervisor, as a master prover, etc. And also as a part of PG program. So in this discussion, I am primarily focusing on CCRH protocol. And the reason for selecting CCRH protocol, I will explain it in the last part of this discussion. And because we need to discuss, we need to differentiate the merits and demerits of different protocols. And I am happy to say that CCRH protocol is the better one among these protocols. So with that reason, I am focusing mainly on CCRH protocol. So one of the study objective of homeopathic pathogenetic trial is to identify pathogenetic effect of a homeopathically prepared drug substance. We call it as investigational proving substance. So here onwards, when I am saying IPS, that indicates the investigational proving substance. That means the drug substance used for, or the drug used for drug proving on healthy human beings. Now, let me see the study design. So here the study design is a prospective, parallel arm, randomized, placebo-controlled study. So the study type is interventional. Allocation, it is randomly allocated. And when you randomly allocate it, it should be either in VRM group or drug group or in placebo group. And this allocation is unbalanced. That means it is not uniformly balanced. So 70% will be in drug group and 30% will be on placebo group. Masking, it is a double-blind study. Comparator, it's a placebo comparator. It is not. There are some protocols where we are comparing the effect of two drugs or two potencies. So here it is a placebo comparator, and the endpoint is disappearance of symptoms appearing during proving and subsequent symptom-free period for 30 years. That means the endpoint is decided based on the symptom, the disappearance of the symptoms which is appearing during the proving, and this symptom-free period should be continued for the next 30 days. If any symptom developed during this 30 days, then again it should be kept for symptom-free period for next 30 days. So that is the endpoint. So that is about the study design. Now about the methodology, the study settings. The study will be conducted as per the CCRS protocol. It should be conducted at the research centers of the council. In coordination with the homeopathic colleges, medical colleges, and identified scientists and faculty of the college will be involved in the study for enrollment of participation, distribution of study drug, recording and reporting of symptoms of the volunteers. So most of the centers where the drug proving is conducted, HPT is conducted as per the CCRS protocol, they're associating the homeopathic medical college nearby with the regional research centers or central research institutes. Now the eligibility criteria. So as per the protocol, the eligibility criteria is the age between 18 to 60 years. Both genders are included, and the health status is preferably good state, both somatically and psychologically. So we have a designated criteria to be an eligible prover in the protocol. So now we'll see what are the inclusion criteria which is given in the methodology. So all of you know that the prover should be apparently healthy. The healthy individual with no apparent disease and normal routine laboratory parameters during screening. So both it should be somatically as well as psychologically healthy, and also the laboratory values should be in the normal limits. Healthy individuals identified as fit for proving by experts. So there are consultants, there are experts to design or to certify that the provers are healthy. Intelligent enough to carefully record the fact, subjective and objective symptoms generated by investigational proving substance during proving. So that means the prover should be able to record the symptoms generated in him or her, both subjective and objective symptoms, and able to differentiate the changes or able to perceive the symptoms generated due to the action of the medicines. The prover should be able to inform the nature of the study and willing to give written informed consent. So the prover should be able to understand the objective, the nature of the study, and also the prover should be able to give a written consent. So these people are included in the inclusion criteria. Now let us see the exclusion criteria. So any disease condition which might compromise any systems in the body. So it can be blood disorders, renal, endocrine, pulmonary, central nervous system, cardiovascular system, immunological, dermatological, gastrointestinal, or any. The person with color blindness, person have undergone surgery in last 2 months, a planned medical or dental treatment during the proving period. That means if it is an emergency, can go for that, but it should be noted. But the planned medical and dental treatment should be avoided. So such people will be excluded from the study. Volunteers on regular medication. Participant must not on any homeopathic remedy in the preceding 1 month. Not only homeopathic medicine, or it can be any medicine, any Irish systems of medicines or any modern medicines. Emotionally disturbed or hysterical or anxious people should be excluded. Persons having non-history of allergies, food, and hypersensitivity. Women during pregnancy, puerperium, or while breastfeeding, and women who have undergone hysterectomy. Smokers who smoke more than 10 cigarettes per day. So this is as per the protocol of CCRH. Recent history of alcoholism, drug addictions, or unlikely to refrain from excessive alcohol consumption or drug intake during the study period. Participation in any other clinical or proving trial during the last 6 months. So these people are excluded from the study. Now about the sample size. So each drug will be proved on minimum 30 participants, including 30% control. I told you the unbalanced allocation of drug and placebo group. So 70% should be from the Viram or drug group and 30% from the placebo group. So out of this 30 participants, adding 20% dropout during the study due to different reasons. So there may be dropouts. There may be some withdrawal of provers during the drug proving due to some other reasons. So minimum volunteers needed to enroll in proving becomes 40. So we are adding a 20% of dropout also to this 30 participants, and it comes around 40. Each center must enroll minimum 15 to maximum 20 volunteers in the program. So that is a minimum sample size for drug proving in one center. We know that it's a multi-centric trial because the same IPS, that is investigational proving substance, will be given in different centers or different areas, different sites. So in each center, the minimum sample size should be 15 to maximum 20 volunteers. So efforts are taken to include at least 20% volunteers from non-homeopathic background. So that many times that may not be possible because the public have many doubts. That is our experience. So it is very difficult to include non-homeopathic volunteers in the drug proving project because homeopathic students are well aware about the methodology. At least they know about the concept of drug proving, but non-homeopathic people are less aware about drug proving. So we are trying to giving some awareness classes and try to include that, but the dropouts are more in non-homeopathic background. That is our experience. Now, the screening of volunteers. The screening of volunteers is a very tiresome task in homeopathic pathogenetic trial as per the protocols, because even though we say that it's apparently healthy, but we need to screen the volunteers for the complete checkup. So the first thing is applications are invited from the volunteers. So that is in Form A. And before going in detail about these processes, let me say, see, this protocol is formulated in 2014, and it was revised in 2017 again. And nowadays, right now, currently, we are entering these applications and other forms through the online mode, through the application, the mobile application. So each student, each volunteers can enter the symptoms or other details through his mobile phone through an app. So that was started in this year, and I'm very happy to say that our institute started it for the first time all over in India, the mobile app. So the applications from the interested volunteers are invited, and these applications are submitted in Form A, and all volunteers will be informed about the objective, the drug proving processes, benefits of the trial, and anticipated risk through a prover information sheet. So before registering, before giving application, the volunteer, the interested volunteer will be given an awareness class. In the awareness class, we will discuss about, we'll explain about the process of drug proving, the methodology, the merits, the disadvantages, all these things, and the prover information sheet will be given to the prover or the volunteers or proposed volunteers. And also, along with the prover information sheet, a written informed consent. Once the prover or the volunteer, the proposed volunteer, is fully satisfied with the methodology of proving, or if is fully willing, then give a written informed consent, and that will be obtained from each selected volunteers before starting the drug proving process. So this is a must, it's mandatory as per the ethical guidelines. The volunteers will be subjected to detailed screening comprising of history and general examination. So that is given in Form C. So once the prover has shown interest, he should be well aware about the proving processes, and the written informed consent is obtained. Following that, a detailed screening will be done comprising of the case taking, the detailed case taking as we do in our OPD, and also a general examination, and that will be recorded in Form C. Now, next important part of drug proving screening is pre-trial medical examination. That will be done in Form D. So what do you mean by pre-medical examination? As I said, the prover should be screened for a complete health, should be free from all diseases. So a detailed pre-trial medical examination for all participants will be taken through a detailed history, as I said, clinical, both general and systemic examination, and also a thorough laboratory investigation to confirm the health status of the participants. So here, the PME, pre-medical examination, will comprise of the history and the general examination, and all the investigation, which include the chest X-ray, ECG, all hematological and biochemical examinations, abdominal ultrasonography, psychological examination by an expert, and all systems starting from respiratory, gastrointestinal, cardiology, neurology, genitourinary evaluations, and for females, gynecological examinations, dermatological examinations, eye examination, and ENT examination. So this is mandatory for all the selected volunteers. So the total PME examination, all these laboratory investigations and all the case taking, general and systemic examinations, all these things should be completed within 2 weeks. There should not be any delay in that. And Volunteers thus identified as healthy by expert will be enrolled in the group. So this is a very important step in the screening of volunteers. And apart from that, one photograph of each selected volunteers in full pose, that means from head to foot, facing camera for record will be included in the PME, pre-medical examination. What is the need of this photograph? This will be only for a record purpose to assess the constitution or the physical makeup, and the photos will not be disclosed in the research data and compiled data or in the publication. So these photos will be kept as a data safety. There are certain data safety measures as per the clinical trial protocol. So that will be kept and it will not be disclosed to anyone. So the photograph is required to assess the constitution, the physical constitution of the prover. Now, about the enrollment of provers, the participants found fit will be enrolled as provers, as I said, and a unique identity code, UIC, will be given based on the next available number on the randomization list. So the will be generated for each prover. So the random generation will be conducted in every stage of proving, or every drug proving method, and the unique identity code will be given for all the provers, and once the UIC is given, a training program for the participants enrolled as provers will be conducted, comprising of details of proving process, expectation from the provers, maintenance of the record. So before screening, one awareness program is conducted. Then we do the pre-medical examination. Again, another awareness program or training program will be conducted with regards to the proving process. Again, expectation. What do you expect? What we are expecting from the provers? So how to record the symptoms. All these things will be explained in the training program. Maintenance of the record, etc., will be given in the training. So this UIC, what is the purpose of unique identity code? So unique identity code for the provers will be used for randomization. So there are intra-individual control. 30% of provers will be randomized into placebo group. So as I said, so and 70% will be in the drug group. So the randomization will be done using a computerized random number chart for allocation to intervention. So this list will be used as a basis for the preparation and labeling of study medication. And intervention allocation will be concealed under the until the proving is over. So once the randomization is done, and that will be done by a third party, and once the randomization is done and the unique identity code is given, that will be concealed until the proving process is until the blinding will be revealed, until the proving process, the method, the proving will be terminated. Now, coding inter-individual control. I told you, inter-individual control, 30% of provers will be randomized into placebo group. And also intra-individual control. The drug placebo sequence will be randomized for each prover in the VRM group. So intra-individual control means in sometimes there may be a crossover design. So at one phase of study, there will be a the prover may get the drug, but the another phase, the next phase, the same prover may get the placebo. But that intra-individual control or the crossover design is not included in the CCRH drug proving. That is given in some other protocols. I think it is given in the LMHI protocol, Liga Medica Homoeopathic International is their protocol. Crossover design is included. Now about the blinding. So the study will be double-blind study, where the site investigators and the participants of the study site will be kept blind about the nature of drug substance, and also the allocation of participants in the VRM and placebo. So even the site investigators or the participants or the experts were not aware about the allocation of drug placebo as well as the participants. The study medication will be sent in a coded form along with the randomization chart. The nature of proving substance will be known only to the principal investigator of the study and the co-investigators sometimes. But the site investigators and the participants will be blind to the nature of the interventional proving substance. So we know that the design of the study is a multi-centric trial, and there will be one principal investigator who is in the headquarters, and there will be site investigators in the different centers. So these site investigators are blinded towards the nature of allocation as well as the nature of the proving substance. Now about the interventions. So what are the interventions? So there are two groups, I said, group 1 and group 2. Group 1 may receive interventional proving substance, and group 2 may receive placebo. So in group 1, the Viram group will be advised to take study medication as per the schedule. This group comprises about 70% of enrolled participants. The interventional proving substance will be given in multiple batches, out of which one batch will be placebo and all the other batches will be interventional proving substance. So then group 2, that is a placebo group, the control group will be given placebo, and we cannot differentiate, we cannot identify which one is placebo and which one is medicine or IPS. And this groups, thus group 2, comprise of the 30% of the enrolled participants. So many times the multiple batches will be given, all of which will comprise of placebo. Both drug and placebo will be same in appearance, odor, and taste. So nobody can identify which one is placebo and which one is proving substance. Now study medication. So study the drugs in compliance with the pharmacopoeial standards from GMP compliant manufacturers are required. The alcohol used to prepare placebo will also be purchased from a GMP pharmaceutical firm, which is approved by council. The proving substance will be prepared in the form of globules of size 30 and will be packed in the form of 1 gram glass bottle, which are labeled with the serial number, prover's code, and date of packing. So each gram bottle will be labeled with a serial number, a prover's code, and the date of packing. The placebo will be prepared similarly. That means the dispensing alcohol is impregnated the globules of size 30. So nobody can differentiate which one is proving substance and which one is a placebo. And labeled in same manner as with a serial number, prover's code, and the date of packing. So the study medication will be labeled with the following information. So what are the informations given in the study packages? The protocol code. So there is a code for protocol. There is a version number for protocol. The study medication protocol that is written. Then the dosage, batches, which batch it is, date, then expiry date, then subject or randomization number. All these things are given in the dram bottle. So in each proving study, the proving substance will be proved at least in 2 potencies and maximum 4 potencies used in ascending order. That means the provings may start from 6C, 30C, 200, and 1. So that will be in the ascending order. Now the dosage schedule. So each batch will have 12 doses, and the provers will be instructed to take 4 pills 4 times in a day. at 4 hourly interval for 3 days. That means in a day, there will be 4 times the prover has to take the medicine or placebo, whatever it may be. And the number of pills taken on each day will be increased consequently in concordance with the organ of medicine, because we know the number of pills taken on each day will be increased. And where it is mentioned that a few more globules may be taken. So that is given in aphorism 2:129. So at every time the prover is taking the medicine, so the dose will be slightly increased. That is why the first day 4 pills, the second day 8 pills, and the third day 12 pills. So this is as per the protocol of 2014. And there are some changes nowadays. We are not increasing the number of pills. And number of doses per day is 4 times in a day. That means 4 hourly interval for 3 days we need to take. And this protocol is for new drug. If the drug proving is conducted for a new drug, suppose if it is a reproving, already established drug, if we are reproving it, then each batch will have 28 doses. That means 28 doses means 4 times in a day for 7 days. That is a dosage schedule for reproving. But if it is for a new drug, then 12 doses. That is 4 times in a day for 3 days. Now, route and method of administration of proving substance and plasma. So the study medication will be prepared in batches for each individual prover. The minimum 3 batches and maximum 5 batches is proposed in one proving. So in a proving, there may be a minimum of 3 batches and maximum of 5 batches. So each batch will comprise of a drug or placebo in globules of size 30. Now, the study medication used in this drug proving will be administered orally as globules, the content of which is allowed to be absorbed orally. So whatever it may be, the proving substance or placebo, it should be dispensed in globules. Now there is a concept called as run-in period. So before taking the drug, the prover, the volunteer has to undergo a run-in period. So what is a drug run-in period? The time period between the completion of pre-medical examination and receipt of the medicine batches by the prover. So before the onset of taking medicine and the completion of PMA, there should be some running period. And this running period will be at least 2 weeks and a maximum of 4 weeks. So what is the purpose of this running period? So the running period, during this period, the prover will be requested to make note of any change in health status and inform the investigator in case of any change in the health. So before taking the medicine, the prover should know how to record the symptoms. So without taking medicine, prover start writing the symptoms or the changes in the health. The prover is requested to fill the prover's daybook pro forma daily, even during the drugging period before taking the medicine. And this will train the provers how to include the symptom, how to perceive the symptoms which is happened in him or her, or how the symptoms are produced. So the prover will get an insight how to record the symptoms. So that is the purpose of the run-in period. So during this period, the site investigator will review the prover's daybook pro forma once in a week, and this run-in period helps the site investigator to check on the willingness and the ability of the participant to properly complete the diary. So this is a trial. This is a trial before actual doing of the recording of symptoms. Running period is a training period for the provers as well as a site investigator. And after that, the investigator will hand over before the running period, the investigator will hand over the prover's daybook pro forma to prover and request to make note of any change in the health status, as I said. Now, next is the drug intake. Once the 2 weeks running period is over, the provers are instructed to take 4 doses in a day, 4 hourly for 3 days for a new drug. And if it is for a reproving, then 4 hourly for 7 days, 28 doses. The number of pills to be taken must be explained properly to the prover. So most often, effort should be made to administer the first few doses, preferably first 2 doses of the coded drug in the presence of the site investigator or the proving associate. So what we usually practice here is, so the day one, the first dose may be taken in the morning, and the second dose may be taken in the afternoon, and the third dose may be taken in the evening. So these 3 doses will be given by the proving associate or the site investigator. So the site investigator or the proving associate is making sure that the prover is at least take 3 doses of medicine. And the rest of the doses can be taken by the prover himself on the next day. So this is what we used to give the instructions. So the provers will be requested to fill the prover's diary book or the daybook pro forma daily and report to the site investigator at least once in a week. If any changes or anything happen to the prover during the intake of medicine, immediately the prover has to report to the site investigator or the proving associate. So the prover must follow the instruction which is given in the participant information sheet and those given by the investigator time to time. So suppose during the time of drug intake, the prover, if there is any signs or symptoms, then he has to report to the site investigator. And once the symptoms start appearing, the prover must stop the intake of the further doses. That is very, very important, and that is given in the prover information sheet. Once the prover started appearing symptom or any signs, he should stop the medication at once and he should report to the investigator. Now, the observation period. So once the prover finished the intake of medicine because of the appearance of symptoms, he should be observed for a period of time. So during the period, the symptom persists, the prover will kept under observation of the investigator. So during the observation period, the symptoms should be written by the prover in the daybook. The prover will be instructed to report the investigator daily as long as the symptom persists. Suppose the symptoms may be there for 1 week, the prover has to report daily to the site investigator. And once the symptom is over, then if any symptoms appear thereafter, he has to immediately report to the site investigator or the proving associate. Now the data recording. So the prover will be expected to make daily record of date and time of intake of study medication in the prescribed pro forma. So before entering the symptoms, the prover has to recheck that he has written the date properly and the time. So date and time is very, very important. The investigator will interrogate the prover about the change in the health status of signs or symptoms during this period and will be record his observation in the symptom elaboration pro forma. So I told you about a daybook pro forma. So daybook pro forma should be written by the prover, and suppose if any confusion in the prover regarding the occurrence of the symptoms or the detailing of symptoms, he has to report to the site investigator or the proving associate, and the site investigator and the proving associate should elaborate the symptoms in another proforma, which is called the symptom elaboration proforma. So there are two proforma to record the proving symptoms. One is to be kept by the prover, that is called as daybook proforma. And another one is an elaboration of the symptoms recorded by the prover in the daybook, and that should be filled by the site investigator or the proving associate, and that should be the elaboration of the symptoms which is already recorded by the prover in the daybook. Hope you understand. Now, how to record the symptoms? So each symptom must be completed. It should be completed in terms of order of appearance. So the first thing is the date and the time of onset. Now the order of appearance, that means a chronological order of appearance. Which symptom comes first, that should be written first. Time of appearance and disappearance. So when the symptom started, when it disappears. So that time should be written properly. Location, the correct anatomical location should be given. Sensation or the character of the symptom. The modalities, the circumstance in which the symptoms worsens or better. So it can be positional, it can be time, it can be position, it can be season, it can be anything which, any change, any circumstances in which the symptom was or it becomes better. So that should be written. Any concomitants, any pathological concomitant or any physiological concomitant. So it can be written. Directions or extension of the symptom should be written. So this is the order in which each symptom should be elaborated. So suppose the prover may not able to elaborate the symptom in the daybook. In that case, the site investigator or the proving associate has to ask about the symptoms in this order. And in the symptom elaboration proforma, the site investigator or the proving associate has to elaborate under this head. Now, each symptom, the investigator on detailed interrogation, the prover will classify and mention the symptom as follows. So, in a symptom elaboration proforma, while interrogating the prover, the site investigator has to make a note of that. Any new symptoms which has not previously explained or experienced during run-in period or observation period. So that should be denoted as NS, that means new symptoms. So I repeat, any symptom which is not obtained during the run-in period after taking the medicine. So there should be a plausible time relation between the intake of medicine and the appearance of the symptoms. So that should be written as new symptoms. Now, unexpected change representing worsening or aggravation of ongoing or recurring symptoms. Suppose any symptoms which is recorded in a running period, which are worsens, which aggravates after the drug intake. So that should be denoted, that should be designated as C-. That means unexpected change representing the aggravation of ongoing symptoms. So that is represented by C-. Now, another set of symptoms which are already there during the running period, but it improved after the intake of medicine. It improved. So that is an unexpected change of representing an improvement of ongoing or recurring symptom. So that is represented by C+. C+. Now the last one is unexpected recurrence of past symptoms. So the prover might have experienced these symptoms in the past, and that is required, or that again it is reappeared during the or after the intake of medicine. So that is represented as RS, that is recurrent symptoms. Recurrent symptoms. So this is how the site investigator or the proving associate has to designate the proving symptoms or to classify the proving symptoms. And also the proving symptoms means not only these symptoms, but also the clinical events or any laboratory findings reported by the volunteers during the trial. And that should be recorded in the final report. And now, if the sign or symptoms appears, so after the intake of medicine, if any symptoms appears, what should the prover do? The prover must stop taking the further dose of study medication as soon as he feels any changes in the health status or any sign or symptoms developed in accordance with the qualifiers of proving symptoms. So I already told about the qualifiers of proving symptoms in the last slide. So what are they? New symptoms, but not previously experienced. Number one, that is NS, unexpected change representing the aggravation of ongoing symptoms. That is represented by C minus. The third one is unexpected change representing the improvement of ongoing symptoms. That is represented by C plus. And unexpected recurrence of past symptoms. That is RS. And also abnormal values of laboratory parameters that were in the normal range during the PM. So during the pre-medical examination, suppose the blood sugar level is in the normal limit. So after the intake of medicine, if it is increased, so that should be included as one of the qualifying proving symptoms. So that is what is called as qualifying or qualifiers of proving symptoms. And suppose the volunteer is not getting any symptoms, if no symptoms or symptoms appears, then till the completion of 28 dose in case of reproving or in case of new drug proving 12 doses, in such case the prover note down as no symptom. So in the day book he has to write no symptoms with the date and time of intake of respective dose of drug, and it should be verified by the investigator. So there are two chances after taking medicine. There may be symptom, there may not be symptoms. So what prover should do if there is symptom, what the prover should do if there is no symptom. So that is clearly mentioned in the protocol. Now regarding a washout period. So what do you mean by washout period? Washout period is after the disappearance of symptoms, a period of 30 days will be kept as a washout period. Okay. So what is the purpose of washout period? So this washout period is maintained to differentiate the carry out effect of the drug. That means the prover will report the investigator once in a week, during which the investigator will interrogate and examine the prover to identify any change in the status. So in case of any appearance of symptom during this period, so once the symptoms are over, a period of 30 days is kept as a washout period. And during this washout period, there should not be any symptoms, any appearance of symptoms. But in case of any symptoms, if there is any symptoms happen during this washout period, then again, we need to wait for the disappearance of the symptoms. Then again, a period of further 30 days should be kept as a washout period that should be symptom free. Okay, so that is what is the importance of washout period, because sometimes there may be a recurrence of symptoms. There may be a period where there is no symptoms, and after 10 days there will be appearance of symptoms. So that is considered as an observation period again. So once the symptoms disappears, then again 30 days should be kept as a washout period. Now, once the washout period is over for 30 days, next process is a post-trial medical examination or post-terminal medical examination. That is same process what is given as in the PMD, that pre-medical trial. So whatever test you have done during pre-medical examination, same will be repeated after the trial, and that is called as post-trial medical examination. And the format is same as in the case of PM, that is Form D. So after all batches of study medications are consumed, and the subsequent washout period of 30 days, the provers are examined again in TME. So before TME, there should be, I told you about 5 batches. So 5 quotas will be given. That means once a run-in period is over, then first quota medicine will be given. So that will be followed by a observation period. And in the observation, if there is no symptoms appears, then and the date on which the symptom disappear, we'll keep it for a 30 days washout. Then after that, the second quota is given. Again, this process is repeated. Now, third quota is given. Again, this process is repeated. And at the end of the 5th quota, the post-trial medical examination is done. The TME must be completed within 2 weeks after the completion of the washout period. Okay, so same as in the case of PME. The PME also 2 weeks, TME also 2 weeks. Now, what are the instructions to the provers? The provers are instructed to follow their normal daily routine and dietary habit till the time he is enrolled in the prover. So there should not be any change in the routine. So in the Hahnemannian proving, we know that in the Hahnemannian proving, there are a lot of changes in the Hahnemannian proving as well as in the homeopathic pathogenetic trial. So I'm not going to explain the differences and similarities, but Hahnemann has given some instructions. So the provers has to follow this instruction strictly. But according to the new homeopathic pathogenetic trial protocol, the prover, the volunteers has to follow the normal daily routine and dietary habit. If he's a vegetarian, follow the vegetarian diet. If he is a non-vegetarian, follow the non-vegetarian diet, etc. So all the provers shall be motivated to adhere to the study schedule or protocol and for the measurement of various investigation from time to time by investigator. Okay, and another thing is the provers are instructed to return the glass containers where the medicine is given with their study medications, and a pill count will be take place. So what is the purpose of pill count? So at least the investigator will know that the prover has taken the required number of pills during the drug intake period. So that can be done. Now, in many circumstances, there may be some withdrawal or discontinuation of prover with some or other reasons. So the prover will be discontinued the proving if there is any occurrences of serious adverse reactions, adverse events, or serious intercurrent illness. So it is a responsibility of the site investigator to maintain the prover in the study. So provided it is safe to do so. Suppose a prover maybe is facing any discomfort, it can be discontinued from the study. So in case of especially a serious adverse event, it can be and it must be documented in the terminal medical examination form. And the prover who withdraws from the study will be requested to undergo a complete terminal medical examination. Suppose the prover is experiencing any adverse drug reaction. So there are some protocols, there are some instructions in the ethical consideration of the drug proving, where if the prover or volunteer is facing any type of adverse event or adverse drug reactions, so there are some protocols to be followed. And that protocol is same for any type of clinical trial. And that should be fulfilled. And another next condition is non-compliance of proving protocol. Sometimes a prover may not able to comply with the proving protocol. So for example, if the prover is experienced any serious diseases or any condition which he may require to intervene with some medications, in that case the site investigator has to withdraw the prover. And if the prover withdraws the consent, it is an informed consent, isn't it? So anytime the prover can withdraw the consent. So that provision is given in the consent itself. Okay, so at any stage of study, trial, the prover can withdraw the consent and he can be naturally discontinued from the prover. And the discretion of the investigator. Suppose the prover is not following the instruction of the site investigator, so he can be withdraw from the provings. So these are the conditions for withdrawal or discontinuation of the proofs. Now the duration. So what are the steps taken during the research center level as well as in the nodal office level? So what are the things which you are doing in the research center? First thing is the prover screening. So screening should be finished by 1 week. Pre-medical examination should be done within 2 weeks. Run-in period should be for maximum for 4 weeks or normally for 2 weeks. Administration of the first batch of medicine, that is for 3 days for a new drug, 7 days for a reproving drug. First washout period is for 30 days plus the days for which the symptom persists. That means once 3 days medication is over, or suppose the prover may get symptoms from the first day itself, so the medicine stopped on the first day and the symptom may persist for 1 week. Suppose if the symptom may persist for 1 week, and from the 1 week onwards 30 days washout period is maintained. So that is what you mean by plus days of which the symptoms persisted. Now next one is administration of second batch, that is also for 3 days, and for reproving drug, that is for 7 days. Second washout period, the same thing, 30 days plus days for which the symptoms persisted. So this process is repeated till the 5th washout period, till the 5th washout period. And once the 5th washout period is, I have wrongly given it as 3rd washout period, that is a 5th washout period. Okay. Once a 5th washout period is given, is over, then next is a terminal medical examination, and that is for 2 weeks. Now, study duration and the processes in the nodal office. So once the TM is over, all the records, all these things are given to the handover to the nodal office, and the and before starting the proving, HPT, protocol preparation, regulatory approval, and pre-trial preparation, all this will take place within 2 months. Now, once a PME documents are sent to the nodal office, the PME assessment, randomization, and allotment of batches and preparation of batches, it takes maximum of 3 weeks. And monitoring and supervision of the study at research level, research center level, that is up to 9 months. So to complete proving from first batch of first quota of medicine to the 5th quota of medicine, it takes almost a minimum of 9 months to a maximum of 16 months, 1.5 years almost. Now, after the proving is over, now the data processing, data compilation and decoding and analysis, it took around 2 months. And further, a report preparation takes 1 month. So this is the time duration, time frame for a proving process at research center level or site and headquarters and nodal office level. Now this is a flowchart for the proving. The first process is the volunteer screening. Hope you are able to see. Once the volunteer screening is over, there will be some exclusion due to some exclusion criteria, and the enrolled volunteers are undergoes the pre-trial medical examination, and during pre-medical examination, some volunteers will be excluded, and there is a final enrollment of volunteers. And the final volunteers are given the prover's code and randomization, and there will be given intervention. 5 batches will be there, and if any symptoms appear, record the symptoms and assessment, observation till the symptom persists, assess for any adverse drug reactions, and if the symptoms disappears, washout period is kept for 30 days, then go for a post-trial terminal medical examination. And in case of there is no symptom, then straight away the volunteers can go for post-trial terminal medical examination. So this is the time frame, the flow chart for the drug proving process. I already explained all these things so far. Now, next is data compilation. So far I discussed about the methodology followed during the process of homeopathic pathogenetic trial. Now, that is a data collection. Now the data processing or data compilation. The phases of data compilation comprise of PME and TME compilation. That means pre-medical examination and terminal medical examination. Prover-wise entry of symptoms produced or symptoms not produced with individual batch should be collected. Decoding and segregation of VRAM and placebo symptoms. Analysis and matching of symptoms and compilation of drug pathogens. So these are the phases of data compilation. The first thing is to verify the PME and TME already taken. After that, the prover-wise entry of symptoms produced or symptoms not produced. Now, after that, decoding. Once you decode, we'll come to know that which all group received the symptoms, which all group received the placebo symptoms. Now, after that, analysis and matching of symptoms and the compilation of drug pathogenesis. Now, this is a dimension of the symptoms occurring during drug proving. So, all symptoms occurring during drug proving. That means, irrespective of the plausible symptoms produced by the drug or due to any confounders, any exterior factors, all the symptoms during the drug proving. So, that is the universal set. Now, under that, there will be proving symptoms. That means the symptoms due to the interventional or investigational proving substance. Under the subset, characteristic symptoms. So among these symptoms, some symptoms are characteristic, and that is a subset of the proving symptoms. So data compilation and analysis by the proving team is a key factor in the translation of raw proving data into meaningful clinical picture that can be used by a prescriber. So we are getting a raw proving data, and this has to be converted into a meaningful clinical picture as we have seen in the mathematics. Then only it can be used by a prescriber. So data analysis process must be carefully designed to avoid excessive inclusion of non-specific, non-characteristic data, because there are symptoms which are due to many other confounding factors. It may not have any plausible relation between the drug intake and the appearance of symptoms. So such symptoms should be excluded from the proving symptoms. So that is a very tiresome group, and there are certain criteria for it. And ensure that the most characteristic and dependable data for the homeopathic prescription should be included. So there is an analysis process to extract dependable homeopathic prescribing indications. That means the reliable proving symptoms from a drug proving, and it all consists of all the proving symptoms, all the symptoms occurring in drug proving, then proving symptoms, and the characteristic symptoms of the drug. Now, the symptom analysis. So how to analyze the symptoms? and how to allocate the symptoms are due to accidental symptoms or the symptoms according to the proving substance, and classify the characteristic symptoms from the proving symptoms. The symptoms will belong to remedy with a great probability. At least one of the following criteria is met. So what are the criteria? Occurrence of symptoms in 2 or more volunteers. If the same symptom occurred in more than 2 volunteers. Objective measurable signs corroborating with symptoms. If any measurable signs is obtained, which can be corroborating with the symptoms. A distant intensity of symptom. If the intensity is more, 3+ in more than 2 volunteers, so that can be a proving symptom. Occurrence of symptoms several times shortly after the administration of drug. So we are conducting the trials in 5 quotas. So every time the same symptom is repeating shortly after the administration of drug. That is why that is what I call it time plausible appearance of symptoms. A recurrence of symptoms several times over a course of several days. So the same symptoms reappearing several period of time. Recurrence of symptoms using different potency. So sometimes there will be symptoms with a 6C potency. So at the next phase, there may be same symptoms with a greater intensity, maybe because of the different potency. Striking singular uncommon symptom can be included as a proving symptom or characteristic symptom. A striking, seldom, paradox modalities or concomitants of the symptoms, which may be appearing more than 2 volunteers. So in this way, all symptoms included, those are appearing in a lesser number of provers or less distinct or common symptoms will be included in the proving data. But symptoms which are not thought to be belong to the drug picture would also be stated, but under separate headings, marked in a specific manner. So there may not be a high intensity, but those symptoms are very less intensity, but it should be included in the proving data, and they are amenable for clinical verification, because these lesser intense symptoms should not be avoided during the symptom analysis, and it can be used for clinical verification. So clinical verification, another protocol is there. So once you clinically verified, that can be included as a part of material. So that is what I want to highlight. So even though if the symptoms is having less intensity, still the symptoms should be included during the analysis. Now, how to designate a characteristic symptom? A proving symptoms are, once the proving symptoms are identified, their characteristic features should be detailed as follows. So how to determine a characteristic symptom from a proving symptom? New symptom with a very marked severity, duration, and frequency. If any symptoms appearing with a very high intensity in more number of volunteers, with a long duration, or more frequently appearing symptoms, so that can be considered as a characteristic symptom. Ongoing or recurring symptom present during proving that have been unexpectedly or markedly improved. Suppose during the running period, there may be some symptoms in some of the volunteers, and that will be better after intake. And that betterment will be unexpected. Then that can be considered as a characteristic symptom. Symptoms that require from the past but not occurred in 12 months preceding the proving. Suppose some symptoms were there in the volunteer, maybe long before, years before, but these symptoms reappeared suddenly after the intake of medicine. Again, the time plausible relation. Then that can be considered as a characteristic symptom. Symptoms that display the alternation with another symptoms in a single volunteer in such a way that alternation is strongly individualized. So we usually say the examples of diarrhea and constipation alternating. If such symptoms are appearing can be included as a characteristics. Symptoms associated with modalities or concomitant acquiring in other parts of the same prover. So if there is a general modality, which that means the same modality can be in a different different parts of the same prover or some other provers. Symptom that involved multiple body parts or organs in a similar manner, or multiple symptoms within the similar same subject with similar associated modality, forming an easily recognizable pattern of reaction. For example, burning sensation. See, in several locations, burning sensation is there, and that can be considered as a characteristic. If same modality in different parts of the body, that can be again considered as a characteristic. Similar symptoms acquiring in multiple provers. Such symptoms may be related by similar sensation, modality, body system, and can be recognized through a quantitative analysis similar to red line symptom reporting in homeopathic literature. So similar symptoms with a strong modality in multiple provers can be a characteristic symptom. Any objective finding, including abnormal X-ray, abnormal laboratory values, associate with subjective symptoms. So that can be considered as a characteristic. For example, dryness of mouth, if found in many volunteers with a increased blood sugar level. So that is a laboratory value. So that can be considered as a characteristic. Now the grading of the symptoms. The symptoms will be graded as follows. The grade 1 symptoms means the symptoms appearing in more than 2 provers, 2 different study sites. That means because this trial is a multicentric trial. So the same type of symptoms appearing more than 2 provers at 2 different study sites. Symptom in 1 or more provers at one site, and similar symptoms in 1 or more provers at second site. That is, if 2 provers separated by distance and time with no contact with each other whatsoever given is the same symptom. So that can be grade 1 symptoms. Peculiar rare cure strains characteristic symptoms. I already given the features of characteristic symptoms in the last slides. Symptoms reappearing from the prior proving. Suppose if it is a reproving, any prior symptoms, any symptoms reappearing from the prior proving. So that also included as a grade 1 symptom. Now grade 2 symptoms, all proving symptoms other than those in the grade 1. So all other symptoms are categorized as a grade 2 symptoms. Now, characterizing symptom analysis, the overall incidence of proving symptom in each trial will be calculated by dividing the number of volunteers who had at least one reported proving symptom by total number of volunteers taking investigational proving symptom. That means only the drug, not the placebo. So this can be done only after the unblinding. Okay, so overall incidence of proving symptoms in each trial. So this is one of the quantitative method of symptom analysis. So previously we have seen the qualitative symptom analysis. Now this is the quantitative symptom analysis. So here the overall incidence of proving symptoms in each trial will be calculated by dividing the number of volunteers who had at least one reported proving symptom by total number of volunteers taking in investigational proving substance. So here the placebo is excluded. Only the drug is considered. The incidence of proving symptoms per volunteer is defined as total number of findings claimed in the trial divided by total number of subjects using investigational proving substance. So here also placebo is excluded. One proving symptom will be counted as a piece of information which could be included in the homeopathic repertoire as an independent subcategory. So this is the quantitative method for symptom analysis, whereby we can calculate the number of the quality of the proving symptoms. Now, assessment of adverse drug reactions. The safety of the volunteers is very important. So safety is important prerequisite for planning a clinical trial. According to the basic principles mentioned in the World Medical Association and the Declaration of Helsinki, every medical research project involving human subjects should be preceded by careful assessment of predictable risk and burdens in comparison with the benefits. So the risk-benefit ratio is always should be assessed, even in the drug proving also, because drug proving is a type of clinical trial as per the Drugs and Cosmetic Act. So drug proving provokes transient proving symptoms, but does not cause any toxicological effect usually. So adverse events should be identified according to HPC-US guidelines as follows. So CCRS protocol, they follow the HPC-US guidelines to assess the adverse events. So that are the durations longer than expected. Suppose if the symptoms appears in the prover and it is prolonged and the duration is longer than expected, so that considers it as adverse effect. Clinical severity greater than expected. If the intensity is more than what is expected, then can be considered as an adverse effect. Clinical severity that falls within definition of serious adverse effect. Serious adverse effect means it has a different meaning, because it may endanger the life of the volunteer, or it may require hospitalization, or it can cause a disability. So such type of adverse effects are called a serious adverse effect, and that requires therapeutic intervention, and it results in the removal of the volunteers from the pool. So adverse event means all the unwanted or clinically significant illness or diseases which is taking place during the study period, no matter whether it is actually closely related to study intervention or not. So there is no, in the adverse event, there is no relationship between the intervention, but in the adverse effect, there will be some plausible relation between the study intervention as well as the symptoms. So this is a flowchart for in case of any adverse reaction. So if any adverse reaction happens, if it is unexpected, then we should see that it meets the criteria for the serious adverse event. If it doesn't meet any criteria for serious adverse event, then it is considered as an adverse event, and we have to see that is unbinding therapeutically is necessary. Unblinding is necessary or not. If unblinding is not necessary, keep blinding until the end of the trial, and we need to determine the causality, whether this the symptom is due to drug or not. We need to go for a causality assessment. Suppose unblinding is required, then there should be premature discontinuation of subject from the trial, followed by the causality assessment. Suppose if the adverse drug reaction is unexpected, then the symptoms can be recorded and subject can be remain in the trial. Now, if it meets the criteria for serious adverse event, then there should be premature discontinuation of subject from the trial, and that should be followed by the unblinding. And if the effect is due to drug, then suspected and unexpected serious adverse event, and it should be immediately report to the CCRH headquarters and report to the ethical committee and include in the data. And if it is it is suspected, expected adverse drug reaction, again, it should be reported to the CCRH headquarters. So this is the flowchart for how we should manage an unexpected adverse reactions. Now, regarding record keeping, the center shall keep track of all participants screened, enrolled, and should maintain a filing system to keep all the study protocol, related documents, source documents, laboratory investigation reports, assessment sheet, medicine distribution records, etc. So all study related data, reports, meetings, minutes, review and assessment records, monitoring records should be kept at one place in the custody of co-investigator. So this record keeping is very mandatory as per the study protocol. So every clinical trial demands the proper record keeping. Now, ethical consideration. So again, this is also one of the very important aspects of the clinical trial. The study protocol follows the international and national ethical guidelines for biomedical research. So that is a standard guidelines for ethical consideration biomedical research. The safety and standardization analysis of proving substance is a prerequisite for all the drug provings. And the proving substance that are proposed to prove taking consideration of safety of all drugs. So all safety considerations should be taken care of. Voluntary written informed consent shall be taken from all participants prior to the participation of study. Only participant found to be healthy, sound body and mind will be enrolled in the study. So the confidentiality should be it's a very prime concern at all stages of the study. And the participants should be informed about the risk and benefit of the study, of the proposed intervention, and available support. Suppose anything happened during the process of the study or the trial, so what support the investigator will give, so that also should be informed to the participants. And finally, the protocol should be approved by the ethical committee of the council. And above all, the participant education shall be conducted for participants in both groups. So these are the ethical considerations which should be followed throughout the trial. And that is about the CCRH drug proving protocol. And apart from this, certain minor things are also there, like prover incentive and confidentiality of the records, all these things. So that I am not included because I have included the protocols. So how these protocol can be followed to conduct a drug proving for undergraduate students as well as for postgraduate students. So, and make you aware about how stringently the protocol is designed in order to exclude all the possible background noises which happens during the proving processes. And I told you about different drug proving protocols apart from the CCRH protocol. So there is a comparison of this. So CCRH, HPUS, European Committee of Homeopathy Protocol, then Liga Medicarum Homeopathic Internationalis Protocol. So here, when you compare all these things, I'm not going to read all these components, but when you see this comparison, we feel that the protocol by CCRH is pretty better one, more protocol wise, more stringent, more robust protocol. And regarding not only regarding the protocol, but also the in case of safety, efficacy testing and safety data, you see the drug substance are administered only in potency, which does not cause any toxicological effect. Whereas in HPCS, there is no such safety data is given. But in ECH, they have given not required as homeopathic remedies are generally safe. So the only that sentence is given. LMHI not applicable to proving. So safety concern is not given in any other protocol apart from CCRS. So patient information sheet is given by all the protocols. The trial method description, CCRS protocol, the methodology is clearly defined. Provings are conducted as double-blind, randomized, placebo-controlled, parallel studies. Whereas in other protocols like HPUS and ECH protocol, the trial method description is not given. Whereas in LMHI protocol, crossover design is recommended. Multiple arms, different potencies are recommended. So that is lacking in CCRS protocol. Crossover design is not given in CCRS protocol. Now regarding control use, CCRS protocol control use is recommended, whereas other protocols controls are not recommended. Randomization is recommended in CCRS protocol as well as HPS protocol and LMHI protocol, but not in ECH protocol. Blinding is given in CCRS protocol. In HPCUS protocol, if permissible by ethical committee, because of some ethical reason, blinding may be prohibited in HPCUS method. LMHI method, it is recommended, blinding is recommended. And in ECH protocol, blinding is not recommended, that is required. And why blinding is recommended? Because to avoid the bias, investigator bias, as well as the volunteer bias. And investigational medicine frequency, each quota of 12 doses, each dose consists of 4 pills, 4 doses in a day, that is the dosage. Whereas in HPUS protocol, dosing timeline established and approved by ethics committee before the trial. So there is no uniform dosage schedule in HPCUS protocol. Whereas in ECH protocol, 1 dose every 2 hourly up to 6 doses in 1 day. Stop if subject believes a symptoms may be occurring. So that is another type of scheduling, dose scheduling. So in LMHI protocol, every 2 hours up to 6 times in a day. So that is another dosage schedule as per LMHI. Now follow-up period is 1 month. Washout period is maintained. After each quota drug is completed, after completion of proving, a terminal medical examination conducted. So none other protocol has given these type of terminal examination and washout. So this is a comparative data available, and this is a published data by CCRH. So thank you for your attention. And now it's a time for if you have any queries, you can ask me. And before that, I extended my sincere gratitude towards the management, the director, the administrator, principal, faculty, and students of Father Muller's for giving me an opportunity and a part of Dynacon, which is conducted on occasion of the 25th year of PG course in homeopathy. Thank you all.
So are there any queries? Are there any queries? Sir, 2 queries have come. So one is, what is the difference between grade 1 and grade 2 symptoms in drug proving?
So I think I have given that in the slide. The grade 1 means more intense, and if the same symptoms are appearing in 2 or more provers with the same intensity, and if the symptoms, there are several criteria which I have given in the slides, like in the same modality, you can observe in the different sites or different provers, which is appeared in more than 2 provers, and if the symptoms appear in 2 provers at different sites during the same phase of study, so these symptoms are considered as grades 1 symptoms. Whereas grade 2, all the other symptoms which are not included in the grade 1. So in the beginning, I told you in the symptom analysis, if the symptoms with a less intensity, we should not exclude it in the symptom analysis, because even though if it is a symptom with a less intensity, that can be relevant during the process of clinical verification. It happens so sometimes, many times. So that symptoms can be included as a grade 2 symptoms, and that will be amenable to clinical verification.
Sir, another query is, do you include third gender for drug proving?
It can include third gender in the drug proving as per the recent ethical guidelines. But as per the CCS protocol or any other protocol, which I have not seen any third gender is included so far, but it shall be included. It must be included. That is the discretion of the ethical committee who gives the permission or approval for the trial.
Okay, so one query from my side. As our drug proving is a multi-centric trial, so we need to obtain the ethical clearance from which ethics committee?
So in a CCRS protocol, we have a council's ethical committee at headquarters, where the protocols is approved and ethically approved by the council headquarters ethical committee, not the site at different sites. Only one ethical clearance is required for drug proving in CCRH.
So there's another query. Is it possible severe symptoms which is danger for the life of pure prover can appear during the drug proving?
Normally, we are proving with potencies in ascending order, like 6C, 30C, 200C, or 1 impotency. So normally, these type of severe adverse events, we call it as severe adverse events, which endanger the life of volunteer, or may require hospitalization, or may require any intervention. Normally, it doesn't happen, but these provisions are given in the protocol, and in the protocol itself, the provisions are given how to manage adverse drug events, even if it is a mild, moderate, or a severe. So that will be given. But normally, we never observed any type of severe adverse event. So there is a difference between severe adverse event and adverse event, isn't it? So severe adverse event never happens in drug proving, in my experience, at least.
Another query is, sir, you are told about a lady who had undergone hysterectomy was excluded. What about person undergone appendicectomy?
That is included in the protocol as the person who undergoes hysterectomy is excluded. Maybe of the reason, see, the symptoms pertaining to the female sexual organs are very, very important. So if you read Roberts, there is a chapter called as weak areas of drug proving, isn't it? So in that he has mentioned about the lack of female provers, lack of female symptoms in the proving data. So if you include a person or a lady without uterus, that means hysterectomy has done, then there may not get some female symptoms related to periods or menses, etc. That may be the reason. Now, appendicectomy means that is a disease condition. So that can be that is not included in the exclusion rate. So that is as per the CCRS protocol.
Sir, any drug proving is going on at present, and where?
Yes, drug proving of 3 batches currently undergone in our center and also in some other centers of CCRH. Right now, we have 3 batches. Right now, one batch, the medication is over. Now they are in a washout period. Second batch, we have already complete. We are going to start with the PME, pre-medical examination, and third batch screening is over. So right now the medicine is, and which drug means, this is a double-blind trial, and we are not aware about the trial, as I said. And after the termination of the drug trial, you come to know that this drug that will be published by CCRH.
So, any more queries? So, hope we are done with the queries. Okay, so over to Dr. Pranay. One more query is there. So, where can we find the notification about drug proving which will be conducted in the future? Where can we find the notification about drug proving which will be conducted in the future?
CCRH notification, and that will be there by the institute where the drug proving is conducted. See, CCRH is having different peripheral centers for drug proving. Almost, I think, 10 to 15 centers are there throughout the country. So they will issue the notification regarding the onset of drug proving project. In our center, recently we have notified and we have enrolled the provers recently, 1 month back.
If washout period is prolonged for months, will there be any alteration in the drug proving protocol?
No, one thing to remember is every participants, every site investigator, every proving associate has to be adhere to the proving protocol. That is a must. And if the washout period is for 30 days, the symptom-free washout period for 30 days, that should be followed. There should not be any prolongation of washout period. There is no necessity in the prolongation because we need to finish the drug proving project within the time frame. So maximum up to the whole process up to 15 months, 9 months to 15 months. So we need to finish it. So there is no need of prolongation unless there is any symptoms appear during washout period. Again, we have to keep it for 30 days. That's all. And at any circumstances, we need to stick on to the protocol.
So after successful drug proving, will the proved drug be entered in HPI?
HPI, yes. That is as per the recommendation of Drug Technical Advisory Board. So once the proving is over by CCRH, that is that medicine is having a sufficient data to be included in the HPI, and which all drug to be included in the HPI has to be desired by the Drug Technical Advisory Board, and they will recommend it to the Pharmacopoeia Commission for Indian Medicine and Homeopathy, and they will include the medicine in the pharmacopoeia.
Okay, sir. So we are done with the queries. Over to Dr. Prani.
Which authority decides which?
Thank you, Dr. Vivek.
So that is decided by drug proving committee by CCRH. There is a committee for drug proving, and they will decide it which drug should be proved in future, or they are already. So if you visit the CCRH website, you can see the proving data of concluded studies, ongoing studies, and the drug to be proved in future. Sorry, that list is not given, but the concluded study details are given. Concluded studies details are given in the website. Ongoing studies details are given not for drug proving, but for clinical verification. Am I clear?
Thank you, sir. I request Dr. Gino Jose, Assistant Professor, Department of Homeopathic Pharmacy, to conclude today's session.
Thank you, Dr. Ram Jyothis, sir, for narrating the HPT in simple yet effective way. Sir has enlightened us about the drug proving of and different types of methodology, how to screen the volunteers, pre-trial medical examination, enrollment of provers for training, coding and randomization techniques, drug dosage and intake period, even data recording, washout period, instruction to provers, withdrawal, study duration, and many more. Thank you, sir, once again. Over to you, Dr. Prani.
Thank you, Dr. Gino. Gratitude is a fairest blossom that springs from the soul. Now, I invite Dr. Joshna Shivprasad, PG Coordinator and Head of Department of Pediatrics, to deliver a vote of thanks.
A very good evening to all the delegates of Dynacon 2023. I feel honored to propose a vote of thanks on this special occasion of the webinar organized by the Pharmacy Department, Dynacon 2023. I, on behalf of the PG Department of Father Muller Homeopathic Medical College, would like to convey my hearty thanks to our administrator, Reverend Father Roshan Krasta, for his support, encouragement, and timely guidance. Thank you, Father. It does not matter where you go and what you study. What matters most is what you share with your fellow beings. I thank our distinguished speaker, Professor Dr. A.B. Ram Jyothis, who has consented to share his expertise through his presentation on homeopathic pathogenetic trial, protocol, and symptom analysis. It was indeed an interesting session for the undergraduate and postgraduates of the colleges. Thank you, Doctor, for the informative session. I would like to thank our Assistant Administrator, Reverend Father Ashwin Krasta, our Principal, Dr. E.S.J. Prabhukiran, Vice Principal, Dr. Vilma Mira D'Souza, Medical Superintendent, and faculty of our different colleges, PG guides, heads of the department, especially Dr. Blanny Lobo, head of the department pharmacy, and his team for their untiring efforts extended to conduct this webinar. My sincere thanks to the non-teaching staff for their immense support. Thank you one and all for your kind cooperation, especially all the delegates from different parts of the country. Thank you one and all for the fruitful session. And good day to all. Thank you.
Thank you, ma'am. Dear delegates, we hope that you have benefited from this session. For all the registered delegates, certificate will be sent to their registered email ID by next week. Myself, Dr. Prani Videra, signing off. Thank you. Have a great day ahead.